Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator. This is session number 39 and the fourth one since our partnership with the American College of Cardiology. Thank you so much for so many of your emails, and I am also grateful to Dr. Fuster. So many questions and comments regarding his interview last time. To our viewers in mainland China, ni hao and welcome you. And hopefully you are able to see our Chinese simulcast. We have another extremely challenging and most complex coronary intervention case today, a trifurcating left main. Let me, without any further delay, take you to the cardiovascular laboratory where Dr. Kinney and Dr. Sharma are standing by, and so that we can show you this case. Samin, good morning.
Well, good morning and welcome to all of our viewers, and especially with the American College of Cardiology. Third in a series, and as you mentioned, one of the very complex case. Of course, those are the type which we want to do and teach various techniques. And I'm very reassuring because knowing that we changed relationship what we were doing 2 years ago for last 2 years with heart.org and now with ACC, that what will happen to our viewers and so, and it is very reassuring if we can show that slide, that which took us 2 years to get to the number of 5,000, we actually got within 2 months with the ACC partnership. It's a really testimony and tribute to ACC educational team and their marketing team done a tremendous job. And goal is very simple, that we want to teach everyone the techniques of it, how we could get to such a great results in most complex cases and in a utmost safe manner, with the being done in 117 countries and so. And I think with that note, knowing that it's a complex case and I had 2 points to cover, that will present this the case with the of today's, which is 70-year-old patient. Actually was just diagnosed the CAD last week with the class 2 angina and positive stress test, and has a 3 vessel and left disease and normal LV. As you can see here, he has asthma on multiple inhalers, and he complains of the GI upset plus minus bleeding, on appropriate medical therapy from our point of view, 2 anti-ischemic therapy and 3 vessel disease, which will show including left main, distal left main being 80%. The whole issue was the high syntax score of 34. Patient comes out of the cath lab. We had to have a discussion with the heart team, surgeons, and of course the cardiologist. Actually, it's the more of a cardiologist, and the patient's belief was no surgery. So then patient went back and had a 2 Cobalt Chromium Everolimus Eluting stent and did well. And issue was that he had GI upset. We added him on 81 milligram of baby aspirin, but he has perhaps mild bleeding, and that was stopped again. Though he came back only on clopidogrel. Oh, he's taking aspirin now.
Yeah.
Okay, then it continued because there was some question did take place, but because of this particular case, high risk, we wanted to make sure there is a adequate platelet inhibition, which have been done, and Anu has tested, and our cath lab staff, all nurses, that PRU, which is a measurement of the inhibition with a verify assay now, P2Y12 assay showed PRU of 182. So means it's a fully inhibited. So clearly, so we don't need to worry about, even if he has to take a aspirin, we can take it off, and so forth. Now Anu will take us through the case.
So if you see the angiogram, his EDP today was 15, is a normal LV function, and this is his right coronary artery. He had stents placed both in the mid to distal area and in the mid portion. He has some disease in the RPL, moderate diffuse, but otherwise stents are okay.
3.5 or 4.0 there?
3.5.
3.5.
Okay. Looks excellent.
Yeah. And this is his left system. Long left main, but significant distal left main, not involving the true bifurcation at the level of the LAD or circ, but then you have a moderate size OM with the ostium about 30 to 50. Your distal circ, which runs in the AV groove, is small, but you have a OM2 significant 95% long lesion, and this is in the cranial view. You see the LAD proximal again ostium is not involved, but 2 diagonals taking off, significant disease of the first diagonal, second diagonal large size, again moderate about 30 to 50 disease. There is calcium also in that area. So this is what we are dealing with the left main, proximal LAD, bifurcation involving the first diagonal, and we have OM2 significant disease.
So tell us your technical approach, what you are going to do. I always ask in complex cases, simple is straightforward. Complex cases for our fellows and attending, that what is the approach. So therefore, you teaching point of view, and to tell us what is your approach here, and so that we do exactly. And that to me, the people say, well, unexpected things happen. No, do not happen. That basically means that you did not risk assess your strategy and the complexity. So this case, what we are going to describe, and in the past we used to have technical pearls for Manu, but basically what I'll do is I'll put her, because she does all the cases, and that I'll put her on the spot, that what you want to do, and that is, I may differ, but we can change it, but the key is that we do exactly what has been committed before the case is done.
Yeah, so here we will do the circumflex first, we will wire it, we pre-dilate it, and just take care of the OM2 pre-dilate and a 28 millimeter or maybe max 33 millimeter stent. Avoid the prox moderate disease area involving the bifurcation of OM, and then we go to the LAD. Here, because there is moderate disease with moderate calcium, significant disease involving 2 branches, we will do rotational atherectomy. The goal then would be just dilate it and 1 stent in the LAD. Then finally coming here, we have to do a cutting balloon, and what we do is take a spot stent of the distal left main involving just before the bifurcation, and then we make a decision whether you have to do a final kiss going into the LAD or and circumflex, but definitely post dilate the distal left main.
Anu, leaving the diagonal alone.
Yeah.
Yeah, I mean again we are a little different. I will do a flex tome of the ostial diagonal and then put a stent across. But therefore that will be the plan, but that we can change.
So that is the backup plan, and we proceed with Anu's strategy right away.
That's fine. Yes.
Okay.
Now with that note, if we can come back, clearly this case is appropriate all the way. We went through all the appropriate heart team discussion, and now here for left main intervention. We are not recommending that this case should go for PCI. This only can happen if the patient does not, after you have presented all the data, and this is where our discussion will be today. What I have made it 2 points: complex CAD, PCI versus CABG, syntax trial, 5-year data presented last month actually, end of last month in European Society of Cardiology, and secondly in the non-complex CAD, PCI versus optimal, routine or maximum medical therapy. So the, whatever it is, usually it's a routine medical therapy in my opinion. That is the data from the FAME2 trial. And in the end actually we'll show also the case from last month, that how the results were. So just to go back to the complex CAD, really where we should go, what we should do, a lot decision is made or we learned by the syntax trial, and now we have the 5-year data, and clearly you can see that from the death point of view, there is some advantage of the CABG over paclitaxel eluting stent, but non-significant. But clear when myocardial infarction, very significant difference in favor of CABG, and of course the CVA, again we thought that we had little advantage, but borderline significance of 0.09. So both mortality and CVA, one in favor of PCI, the CVA, and mortality in favor of CABG. And of course you put these 3 important points, the MACE, which we call death, CVA and MI, that advantage of CABG at 5 years. And remember, syntax trial was the 5-year trial, and of course repeat revascularization we all knew, and so on and so forth. So therefore if you take Mackey and of course the graft occlusion and our stent thrombosis at 5 years is about 5.56% equal in both the groups. But more important is that how do we decide patient multi-vessel disease what to do, and that comes from the syntax scoring system, which assign a numerical number, nothing to do with the clinical context, numerical number to every lesion, and even at 1 year they showed a clear-cut gradient of the syntax low score, we call 22 and less, intermediate 23 to 32, and high 33 and above. clearly it was, there was as you can see with the CABG actually, the red line, bar that you go down when you go to more complexity is the PCI, which goes in opposite direction. So the high syntax score are the problematic. Now these are the 5-year data of the syntax. Low score, again you can see there is no difference in terms of the death. CVA actually in favor more with the PCI, even an MI, therefore clearly only difference is revascularization. Once you go to the intermediate risk score of 23 and 32, you can start seeing the advantage of the CABG over PCI, and once you go to high risk score, of course we lose completely to coronary artery bypass surgery with a first generation drug eluting stent. And this basically is, so now this has, as we know, it has been incorporated in the guidelines of that patient with a high syntax score, whether it's a 33 and above, or it should be between 22 and 32. So all that has been incorporated very nicely. Key is that those patients class 1 indication for CABG. PCI can be done as a 2A and 2B based on the clinical scenario, and that also with the appropriate criteria that only syntax of more than 33 is inappropriate. Other patients with a left main and multi-vessel disease, PCI is uncertain, definitely not in inappropriate category. But at the same time, there are actually the whole discussion takes place with a hard team approach, and decision, ultimate decision is of the patient, and this is where we have incorporated and this now with the 23 and above syntax score and our protocol at Mount Sinai Hospital. But besides syntax, because does not take into account clinical, there have been many other risk classification have come up, and these are one of them is the clinical syntax score, which takes into account patient's age, ejection fraction, and creatinine clearance, and this is called the clinical syntax score, and shown by based on various numbers, and I actually have expert who is going to talk about it. And second is the Euro score, global risk score and syntax combined, which is called GRC, seems to be that you separate take into account the patient's overall condition. Having said that, we actually have done some work at Mount Sinai in multi-vessel disease with various risk score, and Jason Kovacic, my colleague here attending, and I'm sure everybody has seen him, and he's the expert in this field, I would say, the local expert at Sinai, and he'll take you through some of the data which we have and kind of update us briefly in next 2 minutes about various risk scores.
So thank you, Dr. Sharma. This is just a very busy slide, but just to show to you some of the many risk scores that are currently available and are being used to predict outcomes after PCI. The syntax score, as you've seen, clinical syntax. Below that you have the New York State risk score, the ASEF score, which is age, creatinine, ejection fraction. There's a modified ASEF score, NCDR risk score, and down the bottom some others that I've just listed, Euro score, STS, global risk classification, and several others. And what's very interesting about these scores is the relative balance that they give towards anatomical factors in coronary artery disease versus clinical risk factors and clinical predictors. And the balance between those seems to really predict the usefulness of these different scores for predicting outcomes. We actually undertook a review of some 500 to 600 patients at Sinai that underwent PCI with complex triple vessel disease or left main disease. And this is just looking at the initial distributions of these risk scores in some of these PCI patients. And you can see the syntax score is fairly normally distributed, but very skewed distributions for some of the other risk scores, clinical syntax and the ASEF score. If you look at the predictive capacity of these different risk scores for patients with complex disease having PCI, you can see that all of these risk scores are fairly reasonable for predicting mortality. Be they clinical risk scores such as NCDR or ASEF, or anatomical such as syntax. What becomes more interesting is if you look at outcomes such as myocardial infarction, the anatomical risk scores such as syntax and clinical syntax do reasonably well for predicting MI, but some of the other clinical risk scores such as NCDR and the ASEF scores actually don't predict the likelihood of the patient to have MI. What's very interesting is if you look at an outcome like target lesion revascularization, while the syntax score is borderline predictive of TLR, some of the clinical risk scores predict, especially the NCDR, actually predict TLR inversely. So that is to say that the higher your clinical risk by NCDR, the less likely you are to have a TLR. And maybe that's because the patient dies and never gets back to the cath lab due to their extreme clinical comorbidities. Maybe it's because we don't want to take the patient back to the cath lab because they're just at such high clinical risk. But nonetheless, there's this paradox emerging between clinical risk and comorbidities, and they're likely to have TLR. So then when you put all of these things together to predict major adverse cardiac events, which includes MI, death, TLR, etc., none of the scores are particularly fantastic for predicting major adverse cardiac events. So to show you this in terms of ROC curves, area under the curve, you can see for mortality all these scores do fairly well, but for major adverse cardiac events, none of the scores are particularly fantastic. And I think what it's coming down to is you really need to be very clear about what it is you wish to predict, whether it's the likelihood of MI or complications in the cath lab versus likelihood of clinical demise due to clinical comorbidities, and when you apply these risk scores in the cath lab.
Beautiful.
So back to Dr. Sharma.
Yep, I mean just
Jason,
to say,
a quick question.
Of course.
A follow-up question. What, in this particular case, which do you think is the best risk score to follow?
I think clearly that there's incredible clinical anatomical complexity of this case with these lesions, and also there's factors in this case such as the acute angulation of the circumflex and other things which makes this a particularly challenging clinical case from a PCI context. The patient doesn't have a lot of comorbidities, so I think the overwhelming factor in this case is anatomical complexity. I think the likelihood of clinical problems, mortality, etc., is low, but factors related to the PCI, restenosis, etc., may be more of a factor in this patient.
Excellent presentation and beautiful slides too.
great work. Now we go to the second point, non-complex, less complex or simple to intermediate complexity, where PCI has been compared against optimal, regular, maximum medical therapy, and everybody knows about the recent the FAME2 trial presentation and publication in NEJM, and clearly showing that FFR guided with a 0.8 and below, that PCI is superior to maximum medical therapy. Now this is the trial actually was prematurely aborted of 1, 2 or 3 vessel, where at least one lesion had a FFR of less than 0.8, and those who were more than 0.8 but angiographically significant were part of the registry, and basically showed complex slide, but if you can see there, the major primary endpoint largely driven by urgent revascularization with the right lower corner speaks about that PCI was superior to maximum medical therapy, and this actually I have put it very simply. Now if you see here, there was no difference in MI and death in the trial, but because it was short, 6 months they aborted, in my opinion, unfortunate point in terms of our interventionalist, they should have continued a little more because it was only revascularization. But if you can see here that any revascularization was almost 20% in the medical therapy alone, and in the PCI group became 3.1, and if you had a FFR of 0.8, and you can see here the revascularization was 3.6. So the PCI really brought it down to as if your lesion was non-significant. And of course, difference was both urgent as well as non-urgent revascularization as shown in this slide. More importantly, and this is what we all need to remember, that is that of these patients who had urgent revascularization, half of them, means 5.2 of the 11 point, means a total of 11.1, of this 50% of medical therapy alone, while in the PCI again 0.9, means half of them in both medical therapy and the PCI group had a revascularization driven by either MI or unstable angina with EKG changes. So they were not that little chest pain came and we did the intervention. No, these patients were really truly require. Now what will be the impact of this MI on a long term, it need to be seen, and that's where the biggest issue remained from my point of view with understanding of this entire FAME trial. Now of course they went through various landmarks, 7 versus more than 7, and of course angina, PCI did a tremendous job of eliminating angina, as you can see in the very small the blue bar at the bottom of the screen. Now you say what we learned in the FAME was not the new one, that we had this before. One was a small trial called Japanese Stable Angina Pectoris trial, JSAP. As you can see here, this is the trial of about 200 patients, and basically the same story, that there was no difference in death, and so but clearly the death and ACS is lower, significantly lower in the PCI group compared to medical therapy. So that clearly there is a credence that patient you have significant disease. The PCI give rise to a lower acute coronary syndrome, and of course with lower emergency hospitalization. Now second, if you go back to the courage we know overall was negative, but if you go to the 3 subgroups of the courage trial, one done in Canada, USVA and non-USVA. Non-USVA was about 19% of the cases. Now you see the PCI is in blue and red is optimal medical therapy. What do we understand? That clearly that actually it should be other way around. I'm sorry for this slide which we need to fix. That in death and MI was in the PCI group was 15%, and in the optimal medical therapy group was 21% in the US non-VA population. So there is already some precedence to that PCI does better if done correctly. Now we have another paper from New York State database, and that is the matched patients about 938 with a 4-year adverse outcome with a stable CAD who did have a PCI or did not have a PCI or managed on medical therapy, and medical therapy was routine. So it was not maximum medical therapy like courage. And what were the data? The death significantly lower. The patients who had PCI, the death was 10.1% at 4 years in stable patient versus 14.5 in medical therapy group. So also lower myocardial infarction and lower revascularization. So in my opinion, it does make sense, and of course more ischemia it is, better it is. So clearly there is a sense to it that patients with good PCI may benefit. The good PCI may improve the outcome of the stable coronary syndrome. Now having said this, that question always comes, what did we learn from the courage trial? Did we change our practice? Same like what happened in the Berry trial, that patient with the diabetics used to had an advantage of the CABG over PTCA, but Berry trial did not change the practice of the referring and intervention and surgical community in the United States back in 1995. And so same thing happened with the courage. Now you can see here, these are the data from ACC and CDR published in JAMA last year, that if you go with the optimal medical therapy, and they defined optimal medical therapy, that what need to be done for the hypertension, diabetes, renal insufficiency, CAD, and so the pre-courage and post-courage, optimal medical therapy pre-PCI, optimal medical therapy post-PCI, no change in overall patient or of the patient like courage. So basically it just tells you that's so tough to change somebody's practice. So that what we learned, that there is a large practice gap in medical care of PCI patients, important opportunity to develop innovative and aggressive strategy to increase optimal medical therapy in PCI patients both before PCI by the referring MDs, so that patients who have a positive stress test, refractory angina should be on optimal medical therapy before they come to the cath lab, or after PCI by the interventional team will improve the overall prognosis of our cardiac patients. So that is where we are, and of course we are having another little difficulty. We can go back to our angiogram now because purpose was to show the complexity of the case, and let's see where we are, and Anu will tell us. Okay.
Not unanticipated given that sharp angle.
Yes.
This is the 7 French guide though.
Yeah.
Samir, a very important follow-through question in the last statement you made, that courage and fame has not overall made much change in the medical practice. What do you think? Do you think the appropriateness criteria is going to make more changes?
Yeah, actually, to me, I think the appropriateness criteria has made the changes.
Right.
And once the data will come out of the 2011, remember right now in a stable CAD, inappropriate across the board, across the country, every state where they have published the data is anywhere from 12 to 17%. But clearly that patients should not be scheduled for cath and possible PCI until they have been on medical therapy, unless it's a large ischemia, has really changed that. So that those entry means that the referring physician, referring MD is optimizing medical therapy before they come to the cath schedule for the procedure is one way to improve this prognosis. And now Anu, tell us where we are now.
That's a support catheter there.
Yeah,
You need
it's
to
a
hold the
1.5
wire.
balloon.
Yeah.
Okay.
Only thing is because of that aneurysmal portion, we
Yeah.
are not getting into the distal portion of the OM2.
Aneurysmal also,
Yeah.
I don't know if it's a recanalized
Yeah, it could be
CTO
it's
or
behaving like a
something
total
also.
Get a
occlusion.
fine cross.
Samin, two very
Bicornal
important,
whisper.
very relevant questions have come up right away. Two viewers have asked. One is what's the role of FFR and IVUS here?
Yeah, in this particular case, I mean, as you can see here, that patient has ischemia, angiographically very clear-cut 80-90% lesion. Even in the Excel trial, we are part of it, that once your lesion is angiographically more than 70%, it's okay. If less than 70%, then they have to have IVUS minimum, and the patients, particularly if they have no other disease in the rest of the system, isolated left main, then FFR is okay. But otherwise, IVUS with a lumen cross-sectional area of 6 millimeter square. In this case, we can do that. We have equipment, both FFR and IVUS ready, but this will be very difficult. I mean, to me, it's an additional process. If you really need to do something, probably better would be that you do it in the end. Optimize your interventional results after the left main. That there is no dissection left and so.
No,
Okay,
I
now
think we go with the
yeah, we go with the fine. Yeah, now what it will require a little stiffer catheter, probably Confianza and so.
I think we can just do it with the.
Advance. Good.
There's no fielder at all anywhere.
Yep. Yeah, therefore, I think to me, FFR, no. In this particular, some lesion, maybe if you're worried about the LAD or something, is a different story. But FFR is less. IVUS, if there is a question,
What wire
but
you
this
have?
kind of, yeah, but this kind of get across it 100. Yeah.
No,
But
no,
this,
first you have to get the whisper down
yeah,
there.
but this question, this case, in my opinion, I think doing all these fancy things, you'll probably irritate more and then any further benefit.
One of the backup plans would be to just treat the distal left main and not to go after the OMB, if that poses. But let's see. So, I mean, another question has come, a very unusual one, that there's actually a comment here that most heart teams functions very differently. In your hospitals, do both the interventional cardiologist and the surgeon speak to the patient together?
Yes, yes, that's the whole purpose is. Now, sometimes we may not, if the interventional cardiologist is not there, is not the one, then the general cardiologist. Now, many times actually, if there is a general cardiologist, not the interventionalist and the surgeon, if they both are available, then we let them see and discuss with the patient. Will die.
So, in this particular patient, who spoke to the
In this particular patient, actually, the patient's cardiologist and the surgeon.
excellent? And you try to do almost the same way in every
No
case?
wires are making turns.
Yeah. Get up.
Let's
any
go on the
filter
run
wire
through.
left, and you know.
Telling you.
Okay.
180 no good.
The long one is okay. Little die. Now let's go back in.
Let's
We need
go
to
with the.
yeah, we go this one now. We are going to need little stiffer wire here. Yeah,
I
good.
don't know
Hold it
stiffer
down.
wire. Wait.
Don't go too far. Pull back a little bit.
Pull back the other wire.
Bring the screen little closer. Yeah, pull the other wire so we know where exactly it is. Yeah, good.
And one of the views, I
Held back.
almost got a feeling as if it takes off a little higher.
Oh, you're going
But
to the
there,
other
yeah,
branch.
that's a nice.
Yeah, now in the past, this may require actually even venture. Little die.
Yeah, now we are okay.
Yeah, go a little
See,
further
you
on
go
this.
through the lesion up to that
Correct.
aneurysmal segment and
Right.
then
That's where it starts.
curling up.
Yeah, that's what basically means that you need a little stiffer wire. Good.
There is behaving.
Now we have exchange length fielder. We can take exchange length fielder.
That does not behave like a.
Get a curve on the exchange length fielder. You need a little more because this is the whisper wire. You know there is a little shortage of the fielder wires, so that this is. Or if not, we need a little stiffer wire here.
No.
Ready?
Yeah, take it out.
Yeah.
We need the torque for 300.
So, I mean, another
Keep going, yeah.
question, and I'm trying to track down the source of this question. The specific question is, do you think the FAME2 study applies to this patient?
No, but this is beyond frame 2. Frame 2 with the left
Some
main.
die, floor.
But this is not the frame 2 case. I mean, this is the case of, I would say, syntax case.
Right.
Yeah. If any issue, this will be the syntax case, not the frame 2. Cross
Cut
one
it,
more
cut it.
Yeah.
Some die.
Yeah. Yeah. Let's take a picture, okay? Taking a picture.
See that?
Still caught in that aneurysmal area.
So it is not cross it 100. See that? Now you have to make a
Yeah. Or,
flip flop turn.
or we can take a Confianza 9.
No. It's not a concept. Wait. Problem.
It's-
I'll do it. Take the fine cross a little bit out. Yeah, good.
Okay, wait. Some die. Are we there? Sir, take a deep breath. Deep breath. Can somebody tell him take a deep breath?
Cross it you have.
Are we there? Before I advance. Deep breath and hold it.
It's not good.
Breathe normally.
Breathe normally now. Take this wire out. No, not going to work.
Why?
Too floppy. And make it a. Yeah.
Maybe the kinetics may work now. The tip.
Okay. Let me try this one first.
Have a new
Samin,
kinetics.
what wire are you going with?
Yeah. Therefore, earlier the first one was a whisper. Second is the fielder. Now we are going cross it versus Boston Scientific
Kinetic wire.
kinetics.
So a little more stiffness.
Stiffness. Yeah.
Okay.
Yeah. These are the cases, in my opinion, probably will require will require a little stiffer puncturing. If not, then we go to Confianza 9.
That's the kinetics again.
Okay. Just give a little die again.
Pulled it out.
Okay. Little die again.
It's not going to make go. We'll close it now. Leave it.
Little die now.
Exactly in that aneurysmal area.
We are coming back into the same one again. Take this wire out. This is not helping you. Take this wire. Yeah, and actually we have seen the patients with the aneurysmal segments that you cannot, you lose all the torque and energy.
Samin, what about I don't giving it much more shape to the wire? Do you think that would, or it's just coiling in there?
Yeah. Now what we do is that.
Get your thing further down.
Yeah. So now we are going to bring this little bit and a small curve.
It's too stiff to make a turn.
Yeah. It's too stiff to make a turn. That
Turn it,
definitely.
take it off. It's not going to work.
Okay, little die. Take a deep breath now.
You know, I initially thought Whisper would do a very good job
Yeah, I
there,
know.
probably with actually maybe even a more curve. You know, it will just sometimes it just springs
We have
across
the
there.
whisper ready. If this doesn't go, we need the whisper.
Okay.
Quick,
Ready?
out.
Okay. All right. Now we are trying the kinetics.
Okay.
And the next one will be either Whisper or Confianza 9.
I have
no,
not
no,
had the chance
Whisper.
to use the kinetics wire, and I bet you that is happening with a lot of viewers too. Tell us a little more about this wire.
Yeah, it's a Boston Scientific. It's basically that your tip of the wire, spring coil, is further fenestrated.
Okay.
Now, one of the issue had been that it kind of, I would say, behaves more like our the
Stiff,
fielder,
stiff fielder.
a stiff fielder.
They have an extra what is called an incanal ligament, a ligament at the tip for movement of the tip in a better way. Okay, so here.
Where the confine the 9, I'll make a curve.
Why not whisper here?
Where confine the 9. Because I can feel that it's so resistant to move the wire that it's, of course, if you don't see much calcium, but it's a very calcified.
But on the other hand, you need to make that sharp bend through the
Yeah.
aneurysmal
Exactly.
dilatation too.
Yeah. So therefore, that is what I'm going to do. Make two curves.
Right.
Sir, take a deep breath now.
And we thought the challenge would be in the left main.
That's the problem at the bottom.
So that
Curve.
curve
Don't
has
go from
No, there.
that curve has defined the aneurysmal tortuosity.
Yeah. Wire may not come out. Do counter. Move the wire in the opposite direction. Wire has curled up. This is one of the disadvantage. Yeah, let's see. Maybe if you can push a little bit. No?
We may just need the whisper to make the turn there. No?
Okay. Good. Take this out. Wire. Wire is done. No good.
Out.
Okay. Make a curve on your whisper.
Whisper.
Yeah. Now what I've done.
There are already 2 viewers who have suggested just focus on the left main and come and do this later. How about that? Huh?
Yeah. But the question
See,
is
once
how.
you stand the left
Yeah, yeah.
main, we
Then
already
it's
having
going to be
trouble.
hard
Once
to-
we stand the left main, then we are not going to get anything down through that left main stent,
Right.
even if we bring him back later on.
And particularly if you stent across.
Which you, even if you do make it a distal with that knuckle, but it still will require that the question comes is that you may decide not to do it. That's a different story.
Right.
That LED diagonal left main and leave the circ alone. This is subtotal, probably recanalized, will fill by the collaterals. One branch of the circumflex, leaving it alone is not a problem.
Look, this is exactly the beauty of a transmission like this, where you are able to get into the minds of some people and how they are thinking and how differently they would be approaching. And
Make your
You have the
let's
whisper?
let's learn from this
Give me the whisper.
experience. In the meantime, for our viewers, our web address is info@ccclivecases.org, and always remember that all the cases are archived if you need to go back and watch any other case. Samin, also to announce to our viewers that we are in the process of preparing an index. So
Yes.
they'll be able to go and view all the left mains and calcified and bifurcations and
Ready, out, out. I
trifurcations.
know that. That's not going to work. It's so stiff. Nothing is making a turn there. Now this is the wire. If this doesn't go, I think we focus on left main
Yeah,
LED.
that I think in this particular case, particularly we are given all the options, they'll die. Now we also tell people that you may go a little subintimal as long as you know that you have got to the distal lumen correctly. With these stiffer wires is okay. And of course the price sometimes you may have to pay, that if there is a branch, and here is at least no issue in terms of the branch.
I think angulation calcium, there is no one-to-one torque at the tip of the wire.
Right.
Just not, you don't see any movements.
Did we open distal left main at all or no?
We did not. I will try one more wire, otherwise I think we focus on left main and LED. Or we are done. Oh, there. You are there?
Just the threat of that, no? It may be subintimal there.
Subintimal, yeah.
Yeah.
The wire had to, no, subintimal. It's like a snake all over the place. Oh, BM, no, now I think we have created, oh, you mean the other one? No, oh, the new universe.
But let's get a run through once again. I need a run through. We got so good at run through nowadays.
Yeah. I'm not used to whispers. So we are back with the whisper wire now. So deep breath, some die.
You have to pull back a little bit. It's all subintimal.
Yeah.
If we pull back subintimal, we don't reach the aneurysm.
Yeah. No, the problem with the whisper and all these wires are that unless you use a stiffer wire, subintimal is not going to work.
Deep breath, some die.
Yeah.
Hold on.
That's it. You can use the star technique, little integrate star. If make a knuckle.
The viewer has also suggested a Scion wire.
Scion wire is of what company?
I
Some
don't
die.
know. I've never heard that name. SION. Okay, that looks a little more promising there, no? Has a little slightly different. No, this is the subintimal track,
Some
I
die.
think.
Will they again?
There looks no.
It looks a little better.
Yeah, looks definitely
It will be
better.
very stiff advancing anyway, as long as we know that we are there.
I think you're in the right place there.
Take a cine.
We'll take a cine.
No, still the same subintimal
Yeah, leave
passage.
this. Let's go to the LED. Agreed at this time. We have created a lumen. Just one
Take
second.
it
One
out.
second. No, 1 second.
Look, all I can tell you is the same patient coming back 6 months later, you may be surprised how nicely that heals.
Yeah, heals and not
You
only
may
that.
not
it's-
even you may not even need to do anything to that.
yeah, and that you can easily have channel. Many times it has happened with the total occlusions that when they come back, you have a integrated lumen because you created a multiple lumens. So anytime patient comes back with the total occlusion, and we always tell that before going with the same bilateral approach, take a picture. The main time you'll have an integrated channel because that wire has done it.
In the meantime, Samin, our wonderful support staff here has discovered that the Scion wire is a Asahi wire. It's
That
a new generation workhouse with the 3D torque revolutionary style. So excellent. I need to thank Dr. Costa Nicoletatos for this recommendation. Haven't used it, but
No,
we'll
no, but
pass
no,
it.
it's not. May not be. It may not be available in US.
Right, may not be.
Yeah.
But since 117 countries may have people watching us,
Yeah,
that's
absolutely.
a good learning. I'm constantly encouraged. I think you referred to a very
Sunlight.
important point
Not-
today that with the ACC our viewership has caught up, but I do believe that it's also the quality of our audience which has
Go to the LED.
continued to get more sophisticated.
All right. So I think the little change in plan, which is okay. Even if what you commit, you try some, not then.
That you.
Will die now.
Same subintimal.
Yeah.
Okay. We go integrate then. We go to LED.
Okay. But use the same wire.
Yeah.
Go to the LED.
Yeah.
Go to the cranial view.
Okay.
So what the plan is to stent across?
The plan is
No,
now
no,
we
no,
take
we'll,
care of the.
Don't stent across. We can still leave it.
Yeah.
We never give the option.
Right. No, but you're going to keep
leaving.
another wire in the circ in the main.
No, right now we have to do rota, so
Okay.
we don't need another wire there. We will do the rota and then.
So, I mean, another series of questions relating to, are you concerned with the newer wires with the wire entrapment, or that's no longer
No longer an issue.
an issue?
These things are a
Yeah.
problem.
Because we.
Run through.
Yeah, because we have seen that it's okay to trap these wires and so, and as long as it has not made the curve, very simple, and that it is not further curled up, and it's not in the fourth branch, and you are beyond the radio opaque portion, means spring coil. If you have a spring coil at the ostium, then you can you can open it once you try to pull. Otherwise, you can trap the wire and the spring coil portion not to be in a small branch. And then when you are removing it, make sure your guide is out, because guide is going to suck in. Now, very rarely, if you still have a trouble, then you can always go through bring a balloon in the proximal part of the wire. Of course, you cannot go behind the stent, and so proximal portion, then you pull then you start the traction and tension, and then the wire will come out.
I know this is a question from somebody, I think you know, Anshul Jain. Don't you think that once you have a flap in the tortuous lesion, non-coated floppy wires would do better?
Yeah, we tried those also,
Tried
and particularly
that also.
I would say the last one which we tried was which will be in that category is the run through.
No, run through as well as
BMW.
your kinetics. It's
Yeah.
a non-coated floppy tip.
Yeah, but I think I can tell you that it was so, even advancing the little wire was so resistant just at the angle, so that it was a major issue. And whether we, same, we can get a good results. RC has been done. You got a good left main LED diagonal, and then for clearly for LPL or this OM, our goal will be to have a little extra metoprolol dose. Although that we cannot give to this patient because he has asthma, so we have to think about maybe some other.
Well, with such a dominant right coronary artery, I think some of the circulation is going to be covered very nicely with that.
Yeah, this is the one. Go to this view, 2039.
So both the diagonals have some disease, but it doesn't look too bad.
And the D1 definitely significant disease,
Right.
and angle doesn't favor.
So today from the lessons we've learned is not the time to chase angulated branches.
Good.
Yeah, go.
So what wire do you have there now? This is the
We
rota
have
wire?
a rota wire. So
Rota
what
wire,
we
okay.
did was, since we had the fine cross as well as the wire,
175?
we have 175 bar.
Okay.
We use a fine cross and the run through wire to go into the LED. We exchange it to rota wire. We have a 175 bar ready now.
And geographically you would have called this significant enough calcification?
Moderate calcium.
Moderate, okay.
That's the way we have.
Yeah, just hold it there. And I'm going to go, best way, say the calcification you learn, that we just go on fluoro, and you can
Now
see
you
there.
can see.
Not even in left main, it's in the proximal LED.
Proximal LED is more.
But we'll start with the left main.
And some proximal portion of
Yeah.
the circumflex too.
Yeah. Same gap for a few seconds and go back again. 20-second ablation at any time.
I'm advancing the guide a little bit.
Just pulling the wire a little bit.
So here is the tightest lesion,
Right.
having some resistance. Same, slow pecking. Do not push the burr at any time.
But to show the action, that hand
Ablation.
guide should be.
They can't see my hand. You are covering it.
Yeah, not doing it. Showing it.
He has some EKG changes.
So I mean, if you go back and think about it, a few years ago,
Can you increase the speed?
these were kind of cases done with the balloon pump.
Yeah. Yeah, this actually we learned that more and more, and I feel. Okay.
No, I want to do
Yeah.
one more.
I feel actually the shocking result of the shock 2 trial.
Right.
That even in shock it didn't work. Yeah, go. Polish.
But in the shock 2 trial, they use the balloon pump at the end of the case.
So it's shaved off very nicely. Just a few polishing runs now.
You see, it's still not smooth. You see,
Gets caught up in
Yeah.
the right.
done?
When is done?
Yeah, I did left main.
Okay. Coming out with the dynaglide.
Get me the run through wire. Can we just?
Anu, bivalirudin monotherapy.
Yeah, he got Plavix loading 300. We already know PRU of 180, and bivalirudin his ACT is 312.
Is 180 okay, or you want it closer to 200? You're happy with the 180?
Yeah.
No, 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 PRU.
PRU, yeah.
PRU.
that's-
Yeah.
Yeah, it
Yeah,
has to be
therefore
less than
That is
230.
excellent. Yeah.
Yeah, yeah.
And actually, the people are talking about that once you go below 180, you start
Right.
bleeding more.
Yeah.
That you are hyper responder.
Since this guy had a history of actually
bleed.
no history of GI bleed or no, he had endoscopy. Just they found erosion, but nothing else. So he was back on the aspirin. So far, he's doing good with the PPI.
Yep.
So what is your plan now?
I would just, I think, get the balloon, dilate it.
And then we'll leave a
Stand
wire
across.
into the first diagonal. Whether we do something later is a different story, or with any wire. Right now, we put a wire into the protect the diagonal. Yes.
3O balloon.
Yeah, we have a 3020 balloon, and maybe a 33 stent. SS.
Yep.
So, I mean, this is probably one of the most relevant questions to this case today. In your
What is this
mind,
wire?
The rotor wire. Put in the diagonal.
and
No,
I'm going
Don't put this wires
Yes.
on the side. Yes.
I'm going to quote the question as it has come. In your mind, what are the questions going as you decide which stent to use?
Very important. I would say that that has become a less of an issue now with the current second generation stents. Very simple.
How do you choose which of the second generation?
I think one
stents?
very simple, as long as the length is available, and all are kind of identical in terms of the side branch and closure and so, and the myocardial infarction. There may be some data by the resolute all-comer, higher stent thrombosis, but then a few other trials have shown not necessary. But key is that deliverability. Now, some data to support that maybe promus element. So that just to say that thinking process, which used to be very cumbersome with the first generation stents and so, has become very simplified, because kind of the second generation stent are all, the level, the playing field, because all are good deliverability. There is some advantage of all three, one by small and small, advantage and disadvantage.
Are you factoring in things like diabetes for as an example for the Resolute or something?
Yeah,
Have you
that's a very good point. So let's go with the Zions Prime, our Everolimus Eluting Cobalt Chromium stent. You need a different wire, ask them different wire.
Give me a.
Yeah,
you have-
yeah. Therefore, that particular wire, I would say, stent.
the whisper then?
Yeah, that you will use in your run-of-the-mill cases, because has
angle is a
the
problem.
best data in terms of the restenosis and the lowest stent thrombosis. Yes, some cases of the deliverability is the issue, and also the diabetic, particularly insulin-dependent diabetic. So those cases have not done well, or there is no difference compared to first generation stent. So if it's the insulin-dependent diabetic, you probably will think about not using a Everolimus Eluting Zions Cobalt Chromium stent.
Right.
Second, now you go to the platinum chromium. What showed the platinum chromium is a very stiff metal, and it really gives you can go to high
Need a balloon.
pressure, particularly with the calcified lesions, that it can expand lesion very well and continue to have better results at follow-up, so that those cases in a calcific osteal lesion gives you more strength. So we will go with the platinum chromium,
stent, okay.
The platinum, the promus element stent. Now, the disadvantage of it basically is the accordion effect. That basically, if you come a little close, that there is a vertical force shortening of the stent which has been reported. Therefore, we have to be very careful that your guide does not suck in, because there is clearly they have taken one extra connector out, and that has resulted in the shortening. We have seen rare cases, but we have seen that, but clearly has been reported numerous
33
times
Zions.
in the literature.
3.
Then question your
3O.
Resolute I think Resolute, one of the big advantages of the Resolute is it is the probably amongst 3 best deliverable stent. But disadvantage of the Resolute right now in US is it's not a long length, 32 and 39. And secondly, that it has in the randomized trial, it has a higher stent thrombosis against Everolimus Eluting Zions V stent. So that's where therefore in this kind of case, and now of course they get a clear-cut approval in the diabetic patients because the benefit of was quite good in the diabetic also. So a little cutting balloon there and then put the stent across 3.5, 38. One stent and post dilate.
So cutting balloon for the distal left main, is that what you're suggesting?
No, but since we have done the rota, we
Right,
dilate with the
thought,
balloon, maybe put a stent
yeah,
across
maybe.
and then just post dilate.
Anu, that's the direction you're favoring to.
No, I am favoring leave the diag alone.
Okay,
Right,
fine.
okay.
No
Leave
cutting balloon and all this. We already look at that calcified angle we have. You
Okay.
creating trouble.
Yeah, we understand
just put
that.
a stent across and
Okay.
then
And
leave
it's
it. Nothing
not
is going to happen there.
not
Okay.
such a large
38.
branch.
38. Yeah, cover from the distal left main. One lesion proximal part you can
Got it.
dilate with the
3.5.
3.5.
Yeah.
So 3.538.
Yep. And then proximal area we will dilate with a 4.0.
Okay.
And there is a whole concept
So give it a
of
tapered, give it a tapered
Yeah.
appearance.
actually
4
the
or
whole
4.5?
concept 4.5.
Yeah, that
4.5
looks
actually.
almost a 4.5. I
4.5.
thought. Very
4.5.
large left main.
Or 8.
8.
8. 4, 5, 8 if you have. You have?
Yep. 8 or what is that? 8.
Good.
4.5, 8 name. Always just say the name also. Quantum apex. Okay, now this is the 3.5.
38.
38 Zions prime. Good.
Good. Yeah.
No problem getting across there.
No. Okay, good.
Okay. Going up clearly, Zions prime, not more than 12 atmosphere. You need to post dilate it anyway, so that first we need a proximally dilating with the 3.520 and then 4.5 proximal. We need a 3.520 high pressure balloon.
Okay, down.
How much, how maximally, how large expansion do you give yourself? Most people would say that if you have a 3.5 stent, up to 4 is probably okay, but
Yeah, or 0.75.
one
up
millimeter.
to 1 is okay. Although you know, with the Texas, they have shown with the original our Texas Liberty that you could go up to 5 with a 4.0, 5 plus. But I think the 0.75, and that is what has been also in the Excel trial, that you go up to 3.75, I mean 4.0, and then go up to 0.75 more. Yeah, let's take it out.
Now, in this case, take a picture now.
I have some audience already looking forward. They said, how do you follow clinically a patient like this?
Yeah, in this, I mean clearly
Repeat a stress test.
yeah, one
in a
case,
year.
one would be, because here this little shortness of breath and asthma issue and beta blocker will be a major concern for this, because he is on 4 different pumps, although not on steroids yet. And they,
I think let me take out the side branch.
Little plaque shifting in the diagonal.
diagonal,
Yeah, yeah.
So
Both of the
therefore-
diagonals, which we know.
Yeah.
So stress testing at what duration?
Yeah. I mean, if it's
Between 9 months to 1 year. We always recommend that.
Right. Anything different you would do with the left main?
Yeah, actually the same, what we are bringing routinely. Now this case would not be wrong in
Right.
to bring back for the angiograph. This is this is the 3 pi. Oh, sorry, this is what?
What did you give us?
NC what?
NC.
NC track.
Can I
This-
take the wire out? You don't know you dilate
No,
it.
but you have to recross the.
No, take it out. It's a run through.
Yeah.
Down.
So just pull back a little bit, and then you have to recross this diagonal, or maybe leave the wire.
Leave it alone.
Yeah. And proximally. Now the whole question comes is that do you need to do a kissing balloon? Yeah, good. Hold it there. That
No,
up.
hold on. Let me take out the black wire. Okay.
Okay. Pull
Go.
back a little bit. Yeah.
This stuff. Go up here.
This way, okay.
Okay.
Okay. Like you can give the bottle, go.
This is a 3.5 or a
3.520 NC track,
High
and
pressure.
we went at 20 atmosphere. Yeah.
okay.
The proximally will dilate, and then we'll have a 4.5.
The trapped wire, you need to take it out
Right.
before you go high pressure.
Right. At
Before
12
you go to the
atmospheres,
Yeah.
you saw no issue at 12 atmospheres,
Yeah,
but
it
high
came out.
pressure you're
Yeah, high
concerned.
pressure, yeah. Before high pressure, you need to take it
I
out.
think that's exactly the question which had been posed to you earlier today, and I'm glad Dr. Sharma provided the answer.
Yeah. But only question is that if you're going high pressure, that's the time your plaque shift occurs. That
But,
not uncommonly that you'll take the wire out and recross at that level again. You may need to recross it. If need to be, that's what we are going to do now. Bring it to the guide, see what requires, and then 4.5 proximally.
Yeah, maybe with the little
4.58 you have?
nitro, we may realize it may not need.
Yeah.
We didn't take care of the true distal left main.
We have the
That's true,
4.5.
Okay, good.
Yeah. Now, actually, I thought that in our Excel trial, and this is at the time of symposium we learned it, that even if you put a stent across the left main, even in Excel trial, they do not mandate that you have to do a kissing balloon dilatation. I mean, my feeling is that we should do it. We always should do it. But just to say, from the trial protocol point of view, that once you put one stent across, and if you don't want to do a kissing balloon dilatation, is okay. I thought that it's mandated. Now, if you put a stent there, then definitely you have to do a kissing balloon dilatation. Yeah, a diagonal has taken a little beating, but let's dilate with a 4.5 proximally first. Yeah, yeah, it's a 4.58 quantum apex.
Go to the caudal, take a picture, see how the circ looks.
Yeah.
We're going to take a caudal
No,
picture to
looks,
see how the circ costume looks now. Now this one, LAO.
Good. This will be okay.
Okay, go regular man. Good. Okay, hold this.
1 second, we're taking a picture first.
Circ looks unchanged.
Unchanged and ostial. Circ looks okay. Let's go and dilate here. Yeah.
There is also the proximal lesion which we appreciated much better in the circumflex.
Yes.
And
It was there about 50%.
Right,
Yeah.
right,
so
right, which we had deliberately left alone. I have mixed feelings about that diagonal. I think
Yeah,
some people may
I would-
even
I would
favor to
leave it
leave it
alone.
alone. It's not such a big vessel. It has decent flow. So this is a 4.5 non-compliant.
Yes.
So now
Not
isn't
yet,
isn't the
Is feeling good.
proximal part of it at high inflation dilating the segment which we did not touch?
No, no. This is part of the stent. Yeah. No, but has to be.
Which
Has to
hand?
be that way. Yeah. See? Now,
What?
Looks better.
yep. It expanded very well now. And you're right. The proximal lesion of the circumflex
Is looking a little more
yeah,
severe in this
yeah.
view.
The
I
question
had
is,
not-
was it there? See, it was there. When we get to
No,
a
it
better
was there
picture.
all
Yeah.
the time.
Right. No,
but
no,
it
I
looks
think we
more
just
now.
took a different
Yeah.
view. I think
Yeah.
we had not taken
No.
this.
Yeah.
This view will be a better comparison.
Let's get the guide and hold a little bit. All right, looking to me, which I call very, very good. Taken the various complexities and the timings and so on and so forth. Yes, we can do many other things and go forward. The question is, we just
Yeah,
Take it out.
the most
Before you make
gratifying
more
thing in
decision.
that view was the circ is completely unchanged,
Yes.
and I think the diagonal is okay there. Maybe a little nitro. You take a final picture.
yeah, which we did a diagonal of the nitro now. 500 microgram of nitro. Patient developed real nitro toxicity.
Wait. Let's make sure the tag is good. Go.
It's still there. In this particular case, we cannot use a 2B3A because of GI issues.
Right.
Although looks quite good. He has no EKG changes. We can show those EKG. No chest pain now. The one issue, many of these cases we can take care beta blocker, but we can give that here. So I think from all practical point of view, it's okay. We just stop here.
Good.
And patient is fine.
Samin, you were going to give us some follow-up on a patient from last time.
Yeah,
PP?
we will show that also.
Do it. You have the bottle there. But any chest
Yeah.
is okay?
Yeah, 1 second. Yeah.
Better now?
Patient asymptomatic.
Yeah.
Yes, yes.
Okay.
The question is circumflex.
No.
These are two branches of the circ. Everything else remain okay. I think will not be a wrong that if we bring this patient back then this is the case as you mentioned, the follow point of view. I think it will be okay to bring this patient back and at that time try to do a few other things needed for the circumflex and so. I think with that note, I'm going to, as you mentioned, if we go to our last slide, that is the take-home message, which is the incorporation of the syntax and the FAME2 trials, that is in coronary revascularization. Yeah, hemodynamics are fine, no EKG changes, good blood pressure. Can we get the
Yes.
slide on?
We are waiting for your
Yeah.
last
We're going to show
slide.
both things, yeah.
Hemodynamics looks all right.
Yep, that's good. Tell them, slide.
It's,
Oh, external display was a little disconnected. Okay, now. Good. You're there now? Okay, good. All right, so that just to conclude, so that we have gone through our usual, that the long-term data of coronary revascularization for complex extensive CAD, syntax score 23 and above, clearly favors CABG over first generation DES PCI and should become the default therapy by guidelines. Lastly, very important, freedom trial will be presented as the late breaking trial in AHA and really give us guidance in those multi-vessel diabetic patients. Then appropriate revascularization of obstructive lesions guided by physiological FFR less than 0.8 during PCI has shown to achieve excellent long-term results and is superior to maximum medical therapy. So clearly, once your lesion is less than 0.8, you should be working with the doing a PCI. And then of course I have the questions, which is 5-year follow-up of the syntax trial has shown CABG to be superior to DES. The PCI on following component, all-cause mortality, repeat revascularization, CV and MI, you know the CVA. Second question is appropriate dose of IV adenosine for hyperemic response is 140 microgram. Then FAME2 trial, following outcomes in FFR guided PCI, higher readmission, more angina, reduced mortality and lower TLR, clearly lower TLR. And lastly, that in syntax trial of the DS and CABG, stent was used. Basically in syntax, we know it's a paclitac eluting stent. Of the various scores we have spoken, the GRACE score is more for acute coronary syndrome and unstable angina. Now with that note, as you wanted to see our case from last time, the disc, we actually just wanted to show the two pictures if possible.
You can take the camera outside.
Yeah.
in the meantime,
Yeah.
for our viewers, session number 40 is October 16. Anu, as Samin is showing, pulling up this case, another question which came, which I could not cover at that time, was how much do you think is the contribution of debulking in such cases?
Yeah, I think in this situation you saw when we showed you when there is moderate calcium, what happens if you have not done rotational hysterectomy, the question always comes, could you have done this case with just PTCA?
Right.
Yeah, you could have, and then you run into this situation that you are not able to really good expansion even with PTCA. I think you definitely will have more plaque shift into the diagonals trying to get a good pre-dilatation. You may need a couple of stents at that time, couple of balloons to get a pre-dilatations, and that is why I think when you have moderate to severe calcium, definitely if you have access to debulking, is a way to go. And then you saw how the balloon expansion was good with one stent, and the side branch, though there was disease in the first diagonal, but even in the second diagonal we were able to come out without the need for side branch intervention.
Excellent. Samin, are you showing the case from
Slide 1. Okay, good. Now, if we can show, this was the case last time. If we can just quickly show that. Okay, play it again. Remember, this was that complex case.
Yes.
And we got a little challenge, particularly in that case compared to the present one, because this patient had a closure of the LED at that time, and now they just wanted to show the last this was the final results. Excellent. Patient did fine. As you know that during the procedure we put a balloon pump on this patient, has CK about 3 times. Upper limit is here 6.8, and this patient CK was 15. Therefore, again, from interventional perspective point of view, complication, it is either none to minor, because more of the universal definition now is a 5 times of CKMB with the procedure. And patient 48 hours later, we took the balloon pump out next day, and 48 hours later patient went home, and with a follow-up we called him this weekend. He's doing completely fine.
Samin, excellent follow-up. I think viewers would be very happy to see that result, as well as to get an excellent follow-up. Any final words from you, Anu?
Here I think same, we just watching, the guy is better, settled down, heart rate is now, you can show it is 72, no EKG changes, everything is fine, despite 2 diagonals and roughed up circumflex. We say the beaten up artery. Normally we call artery in pieces, it's not in pieces, we beat it up, it looks good, no chest pain. I think we are done with this case. Since we know he had a good PRU, will continue with the Plavix, and the question is how to follow up with this case, especially with left main, 2 stents in the RCA and the circ remaining, that as long as symptomatically is better, we would request a stress test with the primary. He had a positive stress test, so we know stress test will be positive if something happens. Get it done between 9 months to 1 year, and these cardiologists always give a follow-up when they go to see him between 1 month, 6 months follow-up.
Look, a mild dose of humility. I think not every case goes absolutely perfect, but you have an excellent plan here. The patient is doing well. And Samin, words from you?
Yeah, that's. I'm quite satisfied with the results. Personally, if it's my patient, since this is a new patient, will decide. But this kind of patient, I'll bring back in few months, just to see where is the status of proximal circ, and because very complex intervention we did, and he has some choices. That if really we say that no, you develop bad restenosis and should go for CABG, then he has to rethink over. So this kind where a patient where there is no choice, I think clinical follow-up is okay, and with a non-invasive testing. But where there is a choice, and we know that there are still some branches, and circumflex is a good branch, that I personally will bring the patient back in about 3 months, restudy, no stress test that 3 months. Then see if looks exactly same, you want to leave it completely fine, and then do a follow-up as Anu suggested.
Well, hopefully we can bring you that follow-up.
Yes.
Thank you all for viewing. Samin and Anu, excellent job. Great support staff in your cath lab as always. Jason, beautiful slides, excellent presentation, great clinical value. We'll see you next time, session 40 on October the 16th.